Shalom, everyone. My name is Rabbi Lewis, one of the Rabbanim at the Israel Pua Institute. And what we will see today is what we call artificial insemination, which is usually used. The regular procedure which is done today for artificial insemination is what we call the intrauterine insemination, or IUI. We'll see all the medical side of things, and we will refer to some halachic issues related to that. So we'll start with the procedure itself. Starts with a consultation, medical consultation, which really comes to identify whether or determine whether the case of this couple would make sense to go further on with an IUI, because there are some parameters we can know in advance whether that would be the next stage or we should try different solutions, as we will see in a few moments. So the IUI would not be any medical procedure done without proper consultation, medical consultation or professional consultation, to make sure that that would be the preferable procedure. I should say that there is a difference between the system in Israel and the system in most of the world, and especially the United States, where in the United States, the medical system is all private. And here in Israel, the system is public, and medical and fertility treatment is covered by the insurance. And therefore, in Israel, they would try and save money as much as possible and not send couples to a costly procedure when they can do a cheaper procedure and reach some results. However, in the United States, and we've seen that time and again, doctors would send couples to IVF, which is maybe a better procedure, which is with a slightly higher percentage of success, nevertheless, much more expensive than the cheap IUI procedure. So it's worthwhile consulting, making sure that what the doctor tells you is free of personal agenda and is really what the couple should do. Usually, if the IUI would be successful, how much more so the IVF will be successful. But nevertheless, there's no need to go to the more expensive and more complicated medically and halachically IVF. But again, we won't touch the IVF so much today. But nevertheless, the consultation is important on the medical level, whether that's the right procedure to be done. And obviously, another pair of eyes or ears should be also maybe asked to make sure that it's the right thing to do. If IUI is the way to go with our fertility challenge, and we'll see which fertility reasons would lead us towards the IUI, but if it is the case, the first stage will be stimulation. Either injection of medication, which is the common way, or taking oral hormones that will stimulate the ovulation, making sure that there will be, it says here, many eggs. We're not sure we want many eggs. Obviously, many eggs means there's a chance of many children. Truth is that today, more than in the past, we try as much as we can to have a single pregnancy. A multiple fetal pregnancy is not usually considered a success, but rather maybe even a failure, because it's a high risk pregnancy. So we would always prefer a single pregnancy. Nevertheless, if we have a fertility challenge, so maybe we would want 2 eggs to increase the chance of at least one fetus or one single pregnancy. So again, that's a question. Do we want 1 egg or 2? Usually when there are 3 eggs or more, we would not go ahead with the insemination, insemination, because we dread a multi-fetal pregnancy, and that's clearly something we don't want. We don't want triplets. I mean, it sounds nice when they're 7 years old and they dress the same and they go to school and play together and keep each other busy. But as a pregnancy, it can be extremely dangerous, and the chances to lose all 3 or some of them in the better case, or God forbid, have children with again badly affected on the worst case is a very high chance, and therefore we don't really want again clearly triplets, not even twins. We'd rather have them one at a time, which is why stimulation is not always needed. Sometimes, in most cases, stimulation will be given to make sure we have a good single egg. We don't usually want, as I said, 2 eggs or more, especially when the woman is young and we assume she is fertile. We'd rather have 1 good ovulation, 1 good egg, as opposed to 2 or more. And again, scan, ultrasound to make sure that the follicles grow, or the follicle grows properly, mainly making sure we don't have too many follicles. Again, making sure we have 1 good follicle growing and 1 good egg that will ovulate. But again, 1, but not much more, that's for sure. Okay, not 3 or more. So that's the importance of the scan. In those cases where too many follicles will start to mature, in such case, usually we will terminate the procedure and have another procedure next month with a lower dosage, hopefully to make sure that we have less follicles, again, to make sure there's no triplets or not even twins. When we see that the eggs develop and we have a good egg ready for ovulation, we will want to time the ovulation in a time which suits us. So to make sure that we know that we do the insemination in the best time possible. That's a trigger injection. The Ovitrel, which is, I think, the European and Israeli name. I think in the United States it has a different name. Nevertheless, that would be the trigger injection, which will time the ovulation usually within 36 hours or about 36 hours. And that's the other scan, making sure that ovulation is taking place. That scan is not always necessary. If we've scanned the day before and we've seen, or 2 days before, and we've seen a leading follicle, and assuming that ovulation would take place with the trigger injection, we don't always do the other scan. Nevertheless, just again, as we know that the ovulation is taking place very soon because of the trigger injection, that's when the sperm will be collected. The sperm is collected and again, then inseminated in the uterus itself. Nevertheless, we can't take the sperm and inject it as it is into the uterus, because there are hormones within the semen which may cause very strong contractions if they will be inserted in the uterus, which is why they have to be washed. That's a sperm wash. The sperm wash would clean the sperm or the semen from the prostaglandins, which is those hormones which, again, we don't want inside the uterus. And they would then be collected with a syringe and injected into the uterus. And then 2 weeks later, hopefully, we will have a healthy pregnancy starting. So within 14 days, we can already see the pregnancy test. Usually the home kit, as appears over here, is not that sensitive. It's only the blood test that we can take within 14 days of the insemination. And we hopefully would see the levels of the HCG growing, and that will know that the increasing, and will know that the pregnancy has started, hopefully in a healthy way. So that would be the again basic procedure of the IUI. As I said, sometimes we won't take the injections. The injections that a woman would take to stimulate ovulation are usually needed when there's also not perfect ovulation. When ovulation appears to be good, the woman appears to be young, there's no real need for medication. And if we do take medication, in many cases, it will only be the oral hormones. Clomid would be the classic medication hormones taken. Lately, they're moving from Clomid to letrozole, which has a lower risk of multiple pregnancies. And as we mentioned, that's something we want to decrease. Or the gonadotropins, which is injectables that the woman would inject into herself, as a picture of here, Gonalef, Purigon, Menagon, Folistim, and so on and so forth. They're different names, but all do the same thing. And that will, again, enhance ovulation, making sure that there's a good leading follicle that would hopefully turn into a healthy pregnancy. So generally speaking, this is the way it will be done. Okay, is that the sperm will be, as I said, washed, collected, placed in this syringe, and again injected inside the uterus itself, which really saves the sperm cell all the way from the vagina. Maybe over here we can see it a bit more real. So that's the way we've done. This is the speculum, which is the device which the gynecologist would use to open the vagina. And again, take the sperm with this syringe, insert the syringe through the vagina, through the cervix, into the uterus, hopefully towards the upper edge of the uterus, and release the sperm over here. The sperm now has to find its way through the uterus, through the fallopian tube, and meet the egg, which will be collected by the fallopian tube. So that would be released again from the ovary. So that will be the insemination. What really it does, during normal relations, sperm will be ejaculated over here in the vagina, and will have to make its way through through the cervix, or through the vagina, the cervix, up the uterus, into the fallopian tubes, and meet the egg. And this will bring the sperm much closer and allow a larger amount of sperm to reach the egg, because they're, again, in a healthy sample, will have 200 million sperm cell or more, which are ejaculated in the cervix and in the vagina, and they have to make their way through, but only a much smaller amount would reach the egg at the edge of the fallopian tube. The more we bring inside the uterus, the more a sperm cell will reach the egg. So that's the rationale behind the IUI, the insemination. If this works, we'll see it here as well. And if, let's see. Okay, let's see if this works. It's very small, right? So that's the speculum increasing, again, enlarging. That's the sperm cell. I don't know how big you see it, but you see it very small. The sperm will be injected inside the uterus and will make its way from the uterus over here. Don't know if you've seen it big, but nevertheless. Okay, so that would be the procedure. When would we need an IUI? So what conditions will let us use the IUI as a solution? The first normal case will be the major case when we do the insemination and when there's poor sperm count, or the OTA syndrome, which is oligospermia, teratospermia, and astenospermia, which means there's a problem with either concentration or morphology or motility, which I understand you've dealt with the previous lecture of Rabbi Weitzman. So these are the three main criteria we check the sperm. It has to be over a certain concentration to be normal. And if it's under that, we know that that will challenge or compromise the chances to fertilize. Same for the morphology, forms of the sperm cell, and its motility, how fast it moves. And so when it comes to concentration, 20 million per square centimeter would be normal. Sometimes even 15, according to some criteria, 15 million will be normal. Under that, that will mean that we'll probably need some help. Nevertheless, if it goes under 10 million or even under 5 million, that will be too low, and we would normally recommend to skip the IUI and go to the IVF because the chances are not good enough. Nevertheless, there are papers who prove that even with the lower count, the IUI can be helpful. In those places where again price plays a major role in what procedure to take. So maybe to save money, we'll try the IUI, even in cases where if money wasn't an issue, we'll move on to IVF. So again, if the concentration is under 15 or even under 20, usually we would turn to the IUI. When the morphology is under, again, so 4% Kruger is normal. Under 4%, we will consider IUIs. Obviously, when there's at least a year without pregnancy. So we would normally expect pregnancy to happen within a year of trying. If it's less than that and the couple are still young, we will maybe wait. But again, if a year had passed, so we know for a fact that the morphology or the sperm count is low, we would move ahead towards IVF, towards the IUI. The morphology, even if it's 0, it's worthwhile trying IUI because the morphology is the least important of the 3 criteria. In other words, we can probably see healthy pregnancies happen naturally, even if morphology is very low as 0. But again, we assume that if it's under 4, we would see, we'll see it will be more difficult to fall pregnant naturally. And motility, we usually want over 50% of motility and over 40% of rapid motility, and if it's less than that, we would usually try the IUI. If the concentration, again, it's under 10 million or under 5 million, or motility is under 20%, we would probably already move towards the IVF and maybe skip the IUI. But that's where, again, some cases are not questionable and some cases are borderline, so we can consider what's better for us and do we have patience or money and so on and so forth. The other reason when we use the IUI is when there's inability to have normal relations due to an erectile dysfunction. So there are people, for whatever reason, the sexual functioning has failed on the male part, and they can't have relations. Since they can't have relations and they want children, the only way is to retrieve the sperm in different ways and inseminate it directly into the wife's uterus. So that will be another reason why to undergo IUI, and obviously not as common as the Oder syndrome. There are cases where the woman itself cannot, again, the relations can't take place because of the female's part. Two of the most common cases would be vaginismus and the vestibulodynia, which is either uncontrolled contracted vagina to the extent that relations can't take place, or pain during relations which would not allow relations to take place. These things usually have a solution. They can be treated, and usually in a very good way. Nevertheless, sometimes we don't have patience. So it may take 6 months, it may take a year, it may take 6 weeks, but we don't know. Since we don't know, we'd rather start moving things, and we'll do the IUI hoping to reach a pregnancy and then treat the conditions that they're suffering from, whether it's erectile dysfunction or the female problems. And in many cases, the stress of the need to fall pregnant or to reach pregnancy and would increase the inability to heal the problem. And then the minute she will conceive because of the IUI, and again, the stress drops, then they will be able to properly treat these conditions, which, again, the stress because they had to function and reach a pregnancy because everyone around them is falling pregnant. That's something which prevented them from being able to treat their condition. In the case when we use donor sperm, which is obviously on its own a medical question, when we use a donor sperm, obviously then that's the halachic question, then we would need obviously the IUI. And in the cases where there's unexplained infertility, there are cases, maybe 10% of couples, which we don't really know where to put the finger on the problem. It looks like the sperm is okay, the eggs are okay, the uterus is okay, the fallopian tubes are okay, everything looks and functions as it's expected to be. Nevertheless, they're married for over a year and there's no pregnancy. In such cases, we will start with fertility treatment because we don't have anything else really to do. And we'll start with IUI, not knowing it will help, but sometimes we don't know what the problem is, and maybe that will solve the problem. Maybe there is something maybe in the cervix which does not allow the sperm to go through. Obviously, when there's no husband and the woman wants to conceive without a husband, the IUI will be used. Clearly, a halachic question or something we don't really do, what normally we not allow at Puah. When the problem is the sperm low sperm count, we would normally again figure out that through the macro counting chamber. So that's what's used in the labs to check the count. So that will be the standard way to check. They would take the sperm and put it inside the macula, and put this underneath the microscope, and through that they will do it. So that's how it's done in the lab. That's a drop, tiny little drop, as you can see, of semen. It will be covered in such way, placed under the microscope, and that's how they would test. So obviously, they don't have to test the whole sperm sample, which is why there's no great need to bring a huge amount of sperm for a test. So that would be the way to check. And again, this is what a sperm sample would look under the microscope. So this sample has, as you can read, low motility. So you can see only maybe a third of the sperm cell, maybe about a third of the sperm cell is moving. The rest is pretty stationary, hardly moving. And even those which are moving are not moving straight forward. They're not progressive. They're just moving in the same place. And therefore, they would not be able to swim their way ahead and fertilize the egg, and they wouldn't reach the egg. So this is a sperm cell which this is a sperm cell which would again, this kind of sperm cell may even need the IVF, but that might be borderline, depending on how it's defined. What may cause the Otto syndrome? Smoking. That's one. That's a big no-no when it comes to fertility. Also can be responsible for erectile dysfunction. Again, if nothing else will convince the couple, the husband, to stop smoking, this may. Alcohol as well may cause an excessive amount of alcohol can cause a low sperm count. Obesity as well. Again, these three things can cause other bad things. Nevertheless, they are also detrimental when it comes to sperm count. Genetics as well. Again, some men are born tall and others are short. Some are clever and others are less. Some have a good sperm sample and sperm count, and others have a less. So sometimes there are clear syndromes that we know will definitely cause lower sperm count, whether it's Klinefelter or Kalman or other syndromes that we know that will affect the sperm count. But sometimes you don't know. We can't put the finger or the name to the reason. But again, genetics, which will affect many things, and the sperm count. So just some men were born with a lower sperm count, which would lead them towards fertility treatment. Varicocele veins, which you've discussed, I understand, last week, that can also cause a lower sperm count and lead a couple towards the IUI. Partial obstruction can also be a reason for low sperm count. In other words, the production is perfect, but it wouldn't pass through in the right way, and therefore we have to take it and wash it and directly inseminate it inside the uterus. Some medications can also cause a low sperm count. So that's something which is usually known in advance. There's a maybe famous medication called Propecia, which is used for taken by mainly young men for baldness. It's something which apparently works to stop hair loss, but it also stops the production of sperm cell. Luckily, when you stop using the Propecia, within a half a year, the sperm count is supposed to return to its normal count. Supposed to, not always, but usually does return to its normal count. But if a person is taking that medication or other medication which can affect, so that can be a reason for low sperm count, sometimes too low for. So that is another reason. A few more points. Usually, statistics teach us that you should not stop IUI if, again, you fit within the criteria for an IUI. You should not stop before trying at least 3 times. So the fact you failed once or twice does not really mean anything. We would, again, have higher chances after 3 and between 3 and 6. So the standard would be between 3 and 6, not less than 3, not more than 6. And if we've passed 3 and max 6 cycles of IUI and no success, we would normally move ahead towards the next stage, which is usually IVF. There are cases where some doctors would recommend 2 consecutive inseminations. There are different works done on that. Most have shown that it doesn't really help. Which is why we're not really so much for it, or we don't recommend it necessarily. Nevertheless, if that's what the doctor believes can help, there's no reason why not to do it. Nevertheless, sometimes when you do 2 consecutive inseminations, one would be on Shabbat, or one would be before mikvah, and then in that case, we would clearly say that one would be enough. What if the first one happens on Shabbat, or the only one happens on Shabbat before mikveh? We'll obviously discuss in a second. So just to sum up things, the advantages of the IUI over IVF, the in vitro fertilization, is its financial aspect. The cost is much cheaper. I know that's for some unknown reason in the United States, the IUIs are also very expensive. But here in Israel, if you would pay privately, if you're not covered by Kupat Cholim, if you would pay privately, the IUI would be maybe 1,000 shekels, give or take, and the IVF would be 15,000 shekels. So cost-wise, it's nothing to compare. It's, again, less than 10% of the cost of the IVF. So that makes a lot of sense to try that if the sperm count allows that. It's very effective. In other words, if really the main problem is slightly lower concentration, a slightly lower motility, it will breach the gap, right? Just bringing the sperm cell to the edge of the uterus next to the fallopian tubes will make all the difference. So it will just allow you to restore the chances of conception as if everything was good. So it's very effective in the case that again there's a problem with the sperm cell, usually sperm cell. Obviously, when the problem is with erectile dysfunction or no relations, that would clearly be enough. There's no real fertility problem. The sperm cell is perfect, just a technical problem. We have to bring the sperm into the, again, to meet the egg. And it's a short procedure. There's no anesthesia taken. You just come, the procedure is simple. It's not painful. Within a half an hour, you can be on your way back to work. So it doesn't really require much time. Again, there's no anesthesia, so there's no need to recover. It's simple and to an extent even primitive, and done fast. So these are the main advantages of the IUI. And in the cases where that's the medical solution, the reasonable medical solution, we would definitely recommend following that path, not going to the IVF. As I said, IVF is clearly not less effective, and in some cases even more effective. And in some cases where people have no problem with money, is not a problem. They say, if I can afford, why should I not take the best procedure and the best doctor and pay and get the best treatment? Again, it doesn't always make sense, at least when it comes to fertility. What are the halachic challenges that we have undergoing IUI? The first one will be the question of Yochsin. Is the biological father the halachic father as well? So clearly, when it comes to biology, there's no question that the owner of the sperm cell is the father of the child born. But that doesn't always mean that halachically the biological father is halachically the father. Clearly, obviously, right, like a non-Jewish husband who's the father of the Jewish child is halachically not the father. So the biology and halacha don't necessarily go hand in hand. The poskim dispute, not surprisingly, there are at least three opinions, maybe even more, but we'll focus on the main three. The first opinion, and that's the most common opinion, and that's the way we paskin halacha. And lemaise, I don't really know of anyone who paskins otherwise. We hold that the child relates totally to the biological father, and therefore will be his child by all means. He will be inheriting him. He's chayav in kibud avaim, and there's no yibum, and so on and so forth. He will be again, the father is chayav l'lamdot Torah and all the responsibilities and so on and so forth, like a regular biological child. The Beit Shmuel, the Tzitz Eliezer, are only two of many of the poskim who write as well the same. Nevertheless, there are at least two poskim who write otherwise. And even the Tzitz Eliezer, when he brings that opinion, he says that lichora, one can argue, even if you follow that view, that the person who does the hazra'ah maybe is the halachically the father, because the mazriya is the father. So if the father is mazriya during normal relations, so he's the father. But if the doctor is the mazriya during artificial insemination, so maybe the doctor is halachically the father. Nevertheless, again, there are at least two shutim, again, the Avnei Mishpat and the Balivai, who would argue that since it's the bia which defines the fatherhood, and the maaseh of the father has to come with the maaseh of the father. If there's no maaseh, the father is not the father, or the husband is not the father, and therefore, again, he's not related to the child. As I said, that's not a common psak, and I don't know if anyone who really follows that. Nevertheless, because there are such opinions, therefore, we would not go to the a solution of an IUI unless it's really necessary. So it's not something which is without any halachic question or any halachic challenge. And since, according to, even though it's the minority of opinions, there is a problem of yochsin, we would only recommend the procedure if there's a real necessity to undergo the procedure. But if there's a question whether it's the right thing to do, or we can maybe wait a little bit to see if they conceive naturally, and again, medically it would make sense, we would recommend to wait. Some couples, I should say even many couples are stressed and they want children the minute they plan to have children, like everything else comes as they plan. And therefore, if after 2 months they don't conceive, they would start fertility treatment, or would want to start fertility treatment. So again, they can start maybe taking medication, but we would not really recommend the IUI because again, it does have some halachic challenges, even though we don't paskin that way. I should maybe add one more thing I should have said before. The old school was sending couples with Ota syndrome, with low sperm count, so they would send the wife to take Clomid or gonadotropins. So if the sperm is 50%, viable, or 50% of what it's supposed to be. So let's double the amount of eggs and we even it out. So if she has one egg, so the chance to conceive is 50%. If she will have two eggs, the chance to conceive will be 100% or 100% back to normal. And if it's, let's say, the sperm cell is a third of its quality, so we will triple the amount of eggs, and we will have again a balance, the chance to conceive. That's the old school. They don't do that anymore. And if someone does that, it's usually a regular gynecologist and not a reproductive endocrinologist or a fertility specialist. The assumption is if there's a problem with the sperm, we will treat the sperm. If there's a problem with the eggs, we will treat the eggs. But if there's a problem with the sperm, we don't treat the eggs. So increasing egg production or ovulation, enhancing ovulation to compensate for poor sperm cell is not the recommended way medically, and again, it makes sense in halacha as well. The Sridei Esh is concerned because the fact that the person brings the sperm cell to the lab and then to the doctor doesn't really tell us anything about the fact that that's the sperm he used to inseminate the wife. And therefore, we always have a suffix whether the child is really the father's or the husband's child. You never know what sperm he used. So when a couple have relations, so we have a chazaka. The chazaka is that Rov Bilot Achar Abal, and the child is therefore theirs. But if you follow, but if again you only know that she conceived from the husband because that's what the doctor says, and the doctor is not necessarily neman, and therefore we have still a suffix whether whether the husband is really the father. That's what the Sridei Esh comments, and again he's not the only one. Solving that with supervision or halachic supervision will solve that problem. So if we have edus that the sperm that comes from him is a sperm used by the doctor to inseminate, so we remove the suffix of the Sridei Esh. So that will be the first challenge. If the Brit Milah of a child born from IUI happens on Shabbat, so Rav Vosner in Shevet HaLevi says it's Doche Shabbat. In other words, since the child is a regular child, the father is a regular father, the pregnancy is a regular pregnancy, and will be Doche Shabbos because of that. Shlomo Zalman in the Minchat Shlomo and brought by the Nishmat Avram as well, says that there's a suffix, whether it's Doche Shabbat or not. And I know that there are still a few poskim who would not do a bris of a child born from a fertility treatment of IUI, how much more so IVF, would not be Doche Shabbat. That's not the common practice here in Eretz Yisrael. I would assume it's not the common practice in the United States as well. But again, Rav Shlomo Zalman is mistapik whether it is Doche Shabbat or not, because it's to an extent a child that arguably is a Ma'asenissim child, and therefore if it's not B'derech HaTeva, so maybe it's not Doche Shabbat. As I mentioned, supervision is needed. There will be a whole shiur on supervision, why it's done, how it's done, but supervision for IUI and further fertility treatment is necessary to remove any halachic challenges or yichus questions usually. Even if you refer to the child as the child of the father, that doesn't necessarily mean that by having these children, if he has a boy and a girl through IUI, that doesn't necessarily mean that he's Mekayim Pruvu. Nevertheless, the Chelkat Mechokek, the Bet Shmuel quotes the Chelkat Mechokek, and he says, Yesh lehistapek isha shenit abra be'ambati. So the concept of a woman conceiving not through marital relations was a concept that Chazal were aware of and familiar with. So they called it nitabra be'ambati. But nevertheless, the translation of that would be an IUI, a woman who conceived not through normal marital relations. So that's a suffix. If a woman was nitabra be'ambati, ha'im ha'av kiyem purvu ve'im nikra bno lechol davar. So bno lechol davar, we've seen previously that we refer that to him as bno and the father and the husband as the father. But nevertheless, is in Mikayim Pruv or not? That's the suffix of the Chelkat Mechokek. And the Bet Shmuel brings a raya. Yesh le'avi re'aya ma shekatav be'agaat sefer mitzvot katan. So the Smak quotes the Rabbeinu Peretz of the Rishonim, and the Bach brings the same Smak quoting Rabbeinu Peretz, who says that Isha muzheret she'al tishkav al sadin sheshachav alehem ish acher. פן תתעבר משכבת זרע של אחר, גזרה שמא יישא אחותו מאביו. So there's a concern that a woman should not sit on a place where may be remnants of sperm cell of someone else, which is not her husband, and she may conceive from that, and then she gives birth to a child, which the person, the owner of the sperm cell, is the father, and therefore he may marry a sibling, not knowing that he's really a sibling. And therefore, if that's a concern, so maybe you can prove from here that he's bno lechol davar. So if he is considered to be the son of the child, he's bno lechol davar, and at least the Beit Shmuel understands that he's mekayim pru'uvu, because he's bno lechol davar even for pru'uvu. Tzvi Pesach Frank, the Rav Yerushalayim, quotes the similar concept. אפילו למצדדים לומר שנולד על ידי הבת לי אינו בנו לכל דבר, דלא קיים פריה ורביה משום שלא עשה מעשה כלל בפועל לשם קיום המצווה. So maybe if it's נולד על ידי ambati, so again, the person left a sperm cell somewhere and the woman somehow conceived, then he's not Mikayim Puruvu. Nevertheless, when it's an artificial insemination, because you moisi zera, especially for that, and the doctor does the hazra'ah, especially in his name, in Mikocho, in such case as you can't, ein makom lomar shelo kiyem priya verivya is Mikayim Puruvu. Nevertheless, the Tzitz Eliezer does bring opinions that that it remains a suffix, whether it's Mikayim Puruvu or he's niftar, he's exempt from Puruvu, like a ger who's nisgayer and has children the goyusa before he converted. So he's patur from Puruvu, even though he's not Mikayim Puruvu. So that's a suffix which applies. Nonetheless, we usually paskin it is Mikayim Puruvu. How does one provide a sperm sample? So I know you've dealt with that a little bit when you discussed the sperm analysis. So again, there are poskim who say that providing a sperm sample is zera levatola, the Divrei Malkiel and Mishpatei Uziel, to mention two out of many. Nevertheless, most halachic authorities hold that since it's for the sake of pru'urvu, there is no prohibition of zera levatala. Zera levatala, if it's for levatala, it's for the sake of not conceiving. But if it's for the sake of conceiving, that is not levatala. That's the Shlomo Zalman, Adam Moshe Feinstein, and many, many others. There are poskim who say that because of the halachic challenges, especially of providing a sperm sample, one should wait at least 10 years before they can go ahead with the IUI and fertility treatment. That's what the Gemara Yevamos, Daf Samech Dalet says, that only after 10 years of trying, a couple should again divorce and try otherwise, and therefore that's what a couple should wait. The poskim today all say that that was right in the times before we had fertility treatment. Nevertheless, today, since we have fertility treatment and we know exactly what the problem is and we can overcome the problem with fertility treatment, so we don't wait, and we would normally only wait a year with a younger couple and less with an older couple. The way to provide the sample is through a condom, a sterile condom. Shlomo Zalman mentioned that it's a good thing to pierce the condom. Lemaise, we don't recommend doing that. The chances it will tear are too high, and halachically we don't really gain much. And there are many halachic authorities who disagree with the chidush of Shlomo Zalman. We would not necessarily refer to that. There's terminology. There are people who call it the halachic condom. We're careful of saying it's the halachic condom. It's a sterile condom, because if it's a halachic condom, that means you can use it for contraceptive methods purposes, and that's something which is not good. If a condom does not work, so dashmi befnim vezoremi bachutz would be the way to provide a sperm sample for the treatment. Even though doctors would say, and the labs would say, that vaginal collection, which may be good to have for a sperm analysis, is clearly not good for collecting for IUI. You lose a lot of sperm, you lose the quality of sperm, and therefore it's not the way to go. It's true, it's not the way to go, and we would not recommend following that path. Nevertheless, we've seen several couples who've done vaginal collection for IUI and have conceived naturally. So there is, when you watch the sperm, it will be viable also for sperm collected through vaginal collection. Again, that's not the common way of collecting. There are poskim who would say that since there are halachic challenges, especially providing a sperm sample with the IUI, it's mutar only for the mitzvah d'oraisa of pruvu. However, if it's for the mitzvah of lashevet yitzara or la'erev al tanach yadecha, which means having even more children than the pruvu requires, then there's no heter. That's what Moshe writes, and that's the Shevet Halevi, Rav Osner, but Shlomo Zalman, Rav Mordechai Eliyahu, and many other poskim write otherwise. I think it's interesting to see, and things, again, essays have been written, were written on this topic, how halacha, the practicalities of halacha change, and when the procedures become standard and normal. So again, when the Shevet Halevi wrote about IUI, it was a new procedure. No one knew exactly the success rate and how good it is and how common it is. So they were more concerned of doing, undergoing the procedures too many times for La'erev and Lashevet. But today it's, again, is so standard and so common. And again, most poskim with the Hasidische and the Haredi, Litvische, and Sephardi and Sioni world would normally allow having IUIs for the third, fourth, and fifth child, if that's the way to reach pregnancy. We have seen that for some couples, it's hard to provide a sperm sample. It should have been here. Okay, so really this will be here. When a woman is nida, so insemination, when the woman is nida, becomes a real issue. How does one provide a sperm sample when a woman is nida? So you can't do it through relations with a condom. So in such case, one would have to bring the sample through masturbation. The Yigros Moshe writes that that's asur. Nevertheless, the poskim who are matir. And usually what we would paskin at Pua is that if she has been taking medication, the injectable medication, in such case, there is some medical a risk of hyperstimulation, which may lead to a to a medical condition, theoretically potentially dangerous, then we would allow providing a sperm sample through masturbation for the IUI. But if she hasn't taken medication or only taken Clomid, in such case, we would recommend waiting for the next cycle. Unless she's very old and every month is crucial, we would follow the poskim who would be more makel. There is a way to provide with a vibrator or even through electro ejaculation, which is done under anesthesia. Normally, we don't need to follow that path, but those who rather want to follow a Moshe that won't allow masturbation may allow using this procedure. That's not a common way to provide a sperm cell. The best way is to freeze cells, freeze a sample in advance and use it later on in time. That's clearly the best way. Inseminating a woman who's nida maybe is an Isser Koret, but Moshe Feinstein holds against it. The Satmarov, and there's one more opinion, holds that that's a Safek Isser Koret, even though there are no relations. We don't normally pass them like that, but again, try to avoid because there's such an opinion. Is there an issue of Ben Hanida when the insemination is done when she's a nida? So the Shevet Halevi says it's also to do that because of Ben Hanida, Shlomo Zalman, and Rav Mordechai Eliyahu and many others would allow. Bottom line, if there's no other way to provide a sperm sample and they have to do it now because she has undergone injections, we would allow providing a sperm sample through masturbation. Basically, every case has to be dealt based on its own merits. Is there a need for Tvila Lenida de Oraita? There are poskim who recommend. We have seen too many cases where the couple have toiveld for Nida de Oraita, but misinterpret what that exactly means and had relations, even though she hasn't finished her Shiva Nakiyim. We don't normally recommend doing that unless we know for a fact that the woman or the couple would never make a mistake. Is she also Mishum Poletet Shichvat Zera after that? We tend to be matir. The reason is it's because in the uterus and not in the vagina. So there's no concern of Poletet Shichvat Zera. Psichas HaKever does not really apply. The bleeding after insemination is usually a makkah, and therefore it usually doesn't happen. And if it does, it's usually a makkah. So we're not really concerned of that. On Shabbat and Yom Tov, easy to manipulate in advance so it wouldn't happen. So you can plan that in advance. If it does happen and you have a totally non-Jewish staff, the woman is not transgressing any prohibition of her own if it's a non-Jewish staff. If it's a Jewish staff and Eretz Yisrael, it can't really be done. Tisha B'Av and during Avelus, both Rav Mordechai Eliyahu, Rav Hershel Shechter said that it will be mutar. In such case, obviously, it won't be providing a sperm sample, would not be through relations. It will be using a frozen sample, arguably masturbation, depending on the case. IUI from the deceased is maybe a topic we should not be opening at the moment. And I think our time is up. And yeah, if there are any important questions, I'm happy to try and answer. Okay, shkoyach. All the very best.
Thank you.
Okay, shkoyach.